Hello, and welcome back to Nursing 007, End of Life Care. Today's lecture is on symptom management, and I'm your instructor, Katie Smith. So let's begin. What is comfort care? According to Segan's Medical Dictionary, palliative and supportive treatment is for patients who are suffering from a terminal illness, such as AIDS, cancer, or end-stage organ disease, or who have refused life-sustaining treatment. Comfort care is aimed at relieving symptoms, enhancing the quality of the remaining life, and easing the dying process. What does symptom relief mean? Is it reducing the unpleasant feeling like pain or constipation? Is it understanding the social implication of a symptom like a draining wound? Is it listening while a client talks about her grief at never seeing her grandchildren? Yes, these situations are byproducts of terminal disease processes and as such need to be managed for the client to experience comfort care. In end-of-life care management, the family or the social support system is seen as the client as well. What are some typical hospice diagnoses? Well, today cancer accounts for less than half, 37.7%, of all admissions, and currently less than 25% of all U.S. deaths are from cancer. So that leaves quite a few non-cancer diagnoses. The top 4 in 2011 were debility unspecified, dementia, heart disease, and lung disease. Now, as of 2014, debility unspecified is no longer able to be used as a diagnosis, so we should see some different statistics soon. And we also have, along with the primary diagnosis, many comorbidities, and this is largely because most hospice or end-of-life patients are elderly, and elderly people frequently have multiple morbidities. There are often several disease processes with symptoms to treat, which makes it more complex to know which symptoms are being caused by which disease, and also makes prognostication of life expectancy more difficult. Research has being done currently on disease, or rather symptom cluster treatment, and so that is another change we should see in our protocols soon. Assessing symptoms. Some symptoms of end-stage cancer, as well as other diseases, include pain, constipation, diarrhea, dyspnea and cough, fatigue and weakness, anorexia, early satiety or nausea, depression, delirium, and memory loss. The first symptom we'll discuss, and we'll discuss 3 in today's lecture, is pain. The nurse would begin by assessing the patient's severity rate. This is on a 0 to 10 scale, whereby the patient says if the pain is non-existent, 0, or the worst they've ever felt, 10. While this is subjective to the patient, it does give us an objective tool to use when we are assessing efficacy of our intervention. We would also assess the location. Is this pain a primary area, a referred area, an impinged area? The onset, what makes it occur? Is it constant or intermittent? The character, is it an ache, sharp, burning, or dull? This will dictate what kind of intervention we choose. Chronic pain is different from acute pain and needs to be assessed and treated. The differences with cognitive impairment in rating will be in dementia patients. The nurse will use a nonverbal rating scale that will rely on her or his assessment of the face grimacing or posturing or any other type of distress signals the patient may be able to give. And finally, nurses always use the client-rated scale. In other words, if the client says their pain is an 8, even if they don't look like it is, we will always take their word for it, and we will use that accordingly. Modalities to address pain. These will be pharmacological modalities we'll discuss. First of all, analgesics, such as acetaminophen. May not sound very impressive for cancer pain, but often reduces the pain threshold and reduces overall narcotic needs. So we frequently will use acetaminophen as an adjunct. NSAIDs are also used, especially with musculoskeletal pain, although they cannot be used very long term due to GI side effects, but should be considered. Corticosteroids such as dexamethasone are also indicated when there is inflammation. And of course, narcotics are the main intervention for pain, for severe pain, and available in a long-acting pill form, extended release, a short-acting, either liquid or pill form, transdermal patches, subcutaneous and IV infusions. And finally, antidepressants and anticonvulsants are also used as adjuncts, but because these are longer acting or take a longer time to become effective, these are not used in terminal final days, but if the patient has a prognosis of several months, they may be used. Considerations. When the nurse is making a care plan for pain control, the nurse would want to consider scheduling the pain relief versus PRN dosing alone. We would take the PRN doses over a few days and ascertain what that patient had been using, and then make a suggestion to the physician for him or her to schedule the pain doses on a every 12-hour or every 8-hour basis. Anticipating activities that will be painful is a good nursing intervention, and then the nurse can pre-medicate in anticipation of the activity. The nurse also should choose the best route for ease of administration for the patient, but also for absorption, whether it's PO, PR, intravaginal, or subcutaneous or IV. And finally, the nurse should monitor the changing needs due to tolerances, escalating needs, which often happens in end-stage disease, and also changes that addiction or history of drug abuse may bring, as those patients or clients will need a higher dose or more dose. Watch out for side effects. Constipation is very common. Respiratory suppression should not be an issue if you titrate gradually. Sedation, which usually resolves after a few days, is often of concern to clients, but giving them education that they will become tolerant to it and not have as much sedation. These are side effects and not allergies, as is myoclonus, which is a rigidity, sometimes confused with seizures, pruritus, and itching, but not an allergic itching, but a side effect, and then nausea and vomiting, which are not frequent with morphine and could be attributed to other disease processes. It's important not to say that there's a morphine allergy if there are side effects. And finally, non-pharmacological pain interventions might include assessing the environment and reducing stressors, may need to be done diplomatically, positioning the patient for comfort, and other modalities such as aromatherapy, massage, guided imagery, prayer, meditation. All of these can help relax the patient and help with the overall feelings of pain. And finally, exploring other components such as emotional or spiritual distress, which can sometimes be manifest as physical pain. Now we'll talk about the next symptom, dyspnea. Dyspnea is air hunger, or the feeling of not getting enough breath. Can sometimes be described by patients as a tightness and is often seen as a more distressing symptom, even more than pain. This is not the same as tachypnea, which is rapid breathing. One can be dyspneic at a normal rate, and one can be tachypneic and not dyspneic. So the nurse must must assess the patient to see if they have the feeling of not getting enough air. As one might imagine, this easily leads to anxiety and agitation. Some debate exists as to if oxygen is helpful in end-stage disease, but mainly there have not been many studies about it. Oxygen is not an automatic cure for dyspnea. People who are dyspneic should not be assumed to be treated just because they have oxygen. It all comes back to the perception of air hunger. And there is a condition called terminal secretions. It's also known in the vernacular as the death rattle. And that is a pooling of secretions in the final hours, which may or may not cause dyspnea. Medications that are used in the treatment of dyspnea: morphine is the drug of choice, the gold standard. It decreases the feelings of air hunger. Promethazine and chlorpromazine have been found to help dyspnea without the sedation. Anxiolytics are commonly given, such as benzodiazepines, but they have been found to have no effect on the dyspnea, but can reduce the anxiety that comes along with it. So it's important not to only treat with lorazepam or Valium or another benzodiazepine, as that will not actually reduce the air hunger. Depending on the reason for the air hunger, steroids or bronchodilators may also be used, oxygen, as we mentioned, and anticholinergics for the terminal secretions. Non-pharmacological modalities include positioning in semi-Fowlers or high Fowlers, accommodating care in this position. For instance, if the patient cannot be in less than 45-degree angle semi-Fowler, you would not put them flat for a bath. Relaxation therapies are helpful, calming the environment, cooling the air in the room, perhaps to an uncomfortable point for the other visitors, but will help the patient breathe better, and also a cool fan to the face will decrease the feelings of air hunger. And now we're going to have some time for a case study, and I want you to go into breakout groups of about 4 in each group. Apply the nursing process and formulate a care plan. Give rationale. Mr. Jones is a 76-year-old man with COPD. He is in the end stages and has a very poor exercise tolerance. He is short of breath when he transfers to the bedside commode or when he eats. Occasionally, he becomes very anxious that he will suffocate. His lungs move air poorly, with many wheezes throughout the fields. His medications include morphine, immediate release, 5 milligrams every 2 hours, lorazepam, a half milligram, PO every 4 hours PRN, and nebulized albuterol, 1 vial every 4 hours PRN. What are some considerations for his care? Why? We'll pause the video, and when you come back, we'll discuss. Okay, welcome back. Some of the things you may have mentioned: that if he's short of breath when eating, he's at risk for aspiration. He should be sure to eat in high Fowlers and slowly. His morphine is scheduled frequently, but could be scheduled as an extended release every 12 hours for better maintenance. Lorazepam could be scheduled depending on how often he becomes anxious. Oxygen could be tried to see if dyspnea improves. And albuterol nebulizer treatments could also be used aggressively to decrease the wheezes and move air better. The nurse, however, would need to monitor for increased anxiety. And our final symptom is constipation. This can be uncomfortable, but can also lead to abdominal distension, abdominal bloating, poor intake, nausea and vomiting, urinary retention, and confusion. Constipation can also be responsible for poor food and medication absorption, rectal tears and hemorrhoids, bowel blockages, increased medical costs, and unnecessary hospitalizations. What are some considerations? Often overlooked by a nurse, nurses should monitor the bowel movements daily and intervene if no BM in 3 days. Schedule narcotics mandate a scheduled bowel program, and PRN for all clients. Often weakness leads to inability to evacuate the rectal vault, so disimpaction may need to occur. Remember, intake is low, but the bowel wall still constitutes waste. Finally, Constipation can be caused by medications increasing dehydration or decreased peristalsis, disease processes like tumors and fissures, immobility, a lack of help from caregivers, and poor PO intake. Some protocols may be used are stool softeners, laxatives, such as synicides. Bulk type are not good because they require more water. Suppositories PR, enemas are last resort, uncomfortable, or digital disimpaction, which is the antithesis of comfort care, so prevention is always best. Symptom management is important. It's what gives the clients the best quality of life for their remaining time, can actually improve longevity, and improves interpersonal relationships and bereavement of the family members. Thank you for watching, and we'll see you next time.